All right, so good afternoon, everyone, and thank you for joining us for another one of our free educational seminars. Today, we have Dr. Dryson, an occupational physician, and the sections today is Return to Work Implications of Knee Meniscus Injury. Dr. Dryson is an experienced occupational medicine specialist of some 30 years standing. His interests cover chemical toxicity, occupational cancer, occupational stress, and musculoskeletal injuries, including occupational overuse syndrome. He has been working with us for a couple of years now and offers some regular availability on our booking platform. May I ask that you all please remain muted so noises from your home or workplace do not affect the quality of the recording. You will be able to unmute and ask questions at the end of the presentations, or you can type in the chat box if you need to go or don't want to speak up. The recording will be sent out to you within a day or so. Thank you so much for giving your time today to deliver these sections for us, Dr. Dryson. Over to you now.
Well, thank you, Casey. Thank you for that introduction. So just to reiterate, I'm an occupational physician. So my specialty is looking at the effects of health on work and the effects of work on health. Today, I am going to be talking about meniscal injuries in the knee. I do emphasize that I am not an orthopedic specialist, so I'm coming at this from a purely occupational medicine point of view. The knee has two menisci. We'll just have a look at a diagram here. So what you can see there is the meniscus in the dark blue. There's one on the inside of the knee called the medial meniscus, and there's one on the outside of the knee called the lateral meniscus. That pale blue that you can see is the articular cartilage of the femur, and it has the patella or the kneecap in front of it. So you can see that the shape of the meniscus on each side is pretty much like a crescent, and it curls around the medial and lateral compartments of both knees. So when I was at medical school quite a few years ago, no one really knew what the meniscus did. It was thought to just aid in the lubrication of the joint, and back in those days, people used to take out the meniscus without much concern for the future because it didn't appear to make any difference to the function of the knee. What we know now is that the meniscus is essential for normal knee function. These are the functions that I've listed here. It increases the stability of the knee joint. It distributes the load, by which I mean the weight of the body, but also any weights that the person may be lifting and carrying. It does act as a shock absorber, and it does play a part in lubricating the knee joint. So we're going to talk about injuries to the meniscus, and by that I mean a tear of the meniscus. So because tears can occur in various different planes, we've itemized them here for the purposes of this particular discussion. So a horizontal tear is going to be in the meniscus, in the horizontal plane, in other words, running between the femur and the tibia. So it's inside the tissue of the meniscus itself. Now, mostly this occurs just because of degeneration over time. So the inner fibers give way and a tear begins to develop. And as you can imagine, it's more likely to happen in older people, particularly over middle age. So that's the horizontal tear. The longitudinal tear is one that goes up and down in a vertical aspect between the femur and the tibia. The third major tear is a radial tear, which starts from the outside of the meniscus and radiates in towards the center of the meniscus. So those are the three main tears involving the three major planes of the knee. A complex tear involves a mixture of two or more of these horizontal, longitudinal, or radial tears. So this is important when we're considering injury and when we're considering causation, because you can imagine that some sort of force applied to the knee during the course of an accident, for example, could easily tear a meniscus, but it's not going to tear the meniscus in three different directions at once. You need three different forces for that. So a complex tear, which is more than one, either horizontal, longitudinal, or radial, has to be due to degeneration. It can't be due to an acute injury. Having said that, a lot of people with complex tears, degenerative tears, do report significant aggravation of these symptoms after some sort of injury, and it is reasonable to postulate that a tear has been extended or aggravated in one of the planes, but certainly not all three of the planes. Now, once a tear does develop, it can either be completely displaced out of position or just partially displaced. There is a particular type of displacement called the bucket handle tear. And this is like the handle of a bucket, which is looped from side to side from the top of the bucket with a gap in between. And it will generally migrate across the bony surface into the far aspect of the knee where it no longer does any harm. Flap tears are tears which are just partially detached and not completely detached. So we can look at the causes of meniscal tears in two capacities. One is the acute and the other is the degenerative. So an acute tear would normally take place in a otherwise healthy meniscus. And it's due to some physical action such as twisting or turning quickly, particularly if the knee is flexed. It could also be due to a direct blow to the knee, particularly if the knee is bent or twisted, putting the meniscus under strain. So an acute tear generally occurs in otherwise healthy people. It's seen, for example, in athletes. A degenerative tear, on the other hand, as we've already pointed out, may just develop because of the aging process. Over time, the meniscus becomes more friable, it becomes weaker, becomes more easily torn. Having said that, as I've said just before, a degenerative tear can be aggravated by further trauma. So a degenerative tear usually occurs in older people. That makes sense because that's when the body starts to decay. It's often associated with osteoarthritis, that's arthritis of the knee. The knee has three compartments, and the meniscus of the lateral side is in the lateral compartment. The meniscus of the medial side is in the medial compartment. There is a third compartment below the kneecap called the patellofemoral compartment. So osteoarthritis is often seen in the medial and lateral compartments in association with degeneration of the meniscus. It's more common to involve the medial meniscus than the lateral meniscus. And as I've already pointed out, it is usually a complex tear, meaning that it is in more than one plane. So we're now going to look at occupation in respect of meniscal tears. And I've taken my data here from an important study by C. Barnes et al., published in 2021. And this was what's called a systematic review and a meta-analysis, meaning that the authors have extracted all of the studies dealing with meniscal tears and occupation that have ever been published prior to that time. They look at the various studies according to various selection criteria, so they have to be good quality studies. And in this particular case, 22 previous studies met the criteria for analysis. 9 of these studies were included in the meta-analysis. Meta-analysis meaning that all of the results of these studies have been gathered together and pooled so that there is a much larger population under study, and the results are therefore much more robust. So here's what they found, and they use a criteria called effect size, ES, and anything over 0.8 is considered to be a large effect. So kneeling, and we'll talk about how much kneeling this involves a wee bit later, has an effect size of 2.15, quite large. Squatting has an effect size of 2.01, also large. Climbing stairs is 2.28. Lifting more than 10 kilograms or more than 25 kilograms looks pretty much the same. So lifting does have an effect size, but it appears that the actual size of the weight is not all that important. So the authors had a look at some particular occupations. A professional footballer, as you might imagine, has a very large relationship between meniscal tears and their occupation. These are going to be acute tears because they're generally younger people, they're generally fit, and the strain or the injury is generally quite acute. So it would come under the category of an acute tear. Coal miners also have a very large effect size. You can postulate this is due to the position of the knee while they're working underground. Floor layers have a large effect size, but not as big as some of the others that we've been looking at. So floor layers include carpet layers, includes floor tilers. Obviously, they're spending a lot of time kneeling, they're spending a lot of time squatting, twisting, lifting, and carrying. So the same study, the systematic review and meta-analysis, did try to quantify how much exposure would be required before there was a significant risk of a meniscal tear. So you can see that squatting for more than an hour per day for at least 12 months does have a significant risk exposure for a meniscal tear. Standing and walking, on the other hand, and this was defined as more than 2 hours per day for at least 12 months, did not show a significant risk factor with meniscal tears. Walking more than 2 miles per day for at least 12 months also did not show a significant risk factor for meniscal tears. Climbing stairs, however, did show a significant risk factor, and it was identified here as being more than 30 flights of stairs per day. Lifting, again, was significant. Okay, so we've got a meniscal tear. Does it heal? Does it heal by itself? There is evidence that the outer third of the meniscus has a good blood supply, and because of that, it's called the red zone. And because of the good blood supply, it may heal without any further intervention. The inner 2/3 of the meniscus has a poor blood supply and therefore is called the white zone. Because of the poor blood supply, it will generally not heal by itself. This is important because, in fact, most tears are in the white zone. So traditionally, a meniscal tear is treated by surgery, and the surgery is to remove the tear and to trim back the meniscus to what is considered to be healthy tissue. So that's called a partial meniscectomy. It differs to a total meniscectomy, which used to be the operation of favour where the whole meniscus was taken out. So a partial meniscectomy is only in the area of the injury. So back in 2011, there were concerns that people who had had partial meniscectomy were developing osteoarthritis of the knee. So Petty and Lupowitz did a systematic review of all the studies that they could find prior to that time. And they only found 5, but they were studies which did qualify for their criteria. Each of the studies used the other knee as a control. In other words, the knee that had the surgery, they looked at the incidence of arthritis. The knee that did not have the surgery, they looked at the incidence of arthritis, and they compared the two. And the studies range between 8 and 16 years of follow-up following the partial meniscectomy. And it confirmed that there is indeed an increased incidence of osteoarthritis as seen on X-ray following partial meniscectomy. This particular systematic review didn't actually pick up any increased symptoms of arthritis like pain, but following this time, further studies did show that people with the X-ray changes of arthritis did indeed develop symptoms of the arthritis. So this is of concern because pretty much at that time, partial meniscectomy was the only treatment for a torn meniscus. So a review was carried out by Bo Feast and his co-authors in 2017. And it was done on the basis of a review of all the literature up to that point, plus the opinion of an expert panel of orthopedic knee surgeons. And it's a lengthy findings, but I've just listed down a few here, which I think are of interest and importance. There had been studies comparing people who had had partial meniscectomy with what was called sham surgery. In other words, they were given the anesthetic, they had the incision over the knee, insertion of the arthroscope, but no actual surgery took place. And there was no difference between people who had had surgery with people who had had sham surgery, indicating that surgery may not be of any particular benefit anyway. There were other risks for a poor outcome, and these included being overweight, which you might understand, being on the lateral side of the knee, the lateral meniscus, but also the presence of damage to the chondral cartilage in the knee, which is osteoarthrosis. So the conclusion of this expert panel was that surgery is in fact not recommended for the first line of treatment in someone with a meniscal tear. and particularly if it's a degenerative tear. They made the point that if there is advanced osteoarthrosis, then surgery is not indicated at all. The only time that surgery might be considered if there were mechanical symptoms present. And by that, I mean symptoms of the knee locking, jamming, pain under load, things like that. So since that time, there have been attempts at looking at alternatives to partial meniscectomy surgery. So one obvious one was repair of the tear, which simply means putting some stitches in the tear and bringing them together. Remember that if this is in the white zone, there is very poor blood supply anyway, so these tears tend not to heal even after repair. So some other possibilities, and I have no personal experience with any of these, this is all information that I've gained from the medical literature. An allograft is a graft into the meniscus, and it shows after 10 years that the graft survives, so it's not a bad way to treat a meniscal tear. A meniscal scaffold is a mechanism that allows the meniscal tissue to grow into it and thereby regenerate. There's been looks at partial meniscus substitutes and attempts at looking at regeneration of the meniscus, in other words, to regrow the meniscus. This is futuristic. It's not currently available as I understand it. What else can you do for meniscal tears, particularly after osteoarthritis sets in? Well, it's the total knee joint replacement. So Bracey and colleagues in 2024 looked at the outcome of knee arthroscopy following both meniscus repair. Only 1.7 required to proceed to arthroplasty, I beg your pardon. After meniscectomy, 8.4% needed to proceed to arthroplasty. Arthroplasty meaning the joint replacement. So what's that? Something like 4 times as many subjects required knee replacement after meniscectomy as they did after a meniscal repair. Again, there are other risk factors: male sex, overweight, smoking, and by comorbidities is meant other conditions in the knee, such as, for example, cruciate ligament tears, arthritis, any other comorbidity in the knee. So if we're looking at return to work after a meniscal injury, and this is what my session is all about, there are all these factors that we need to look at. The first is the difference between an acute tear, which generally has a good outcome, and a degenerative tear, which generally has a bad outcome. You will recall that if the tear is in more than one plane, then the outlook is bad. The outlook is for development of osteoarthrosis. The outlook is for further extension of the tears. We need to look at the occupation of the person concerned. If there is significant squatting and kneeling, climbing stairs, lifting and carrying, then we need to look at some form of alternative occupation or changing the tasks of their current occupation so that they can get back to work. The older the patient, of course, the less likely that they are able to get back to their previous occupation. So I hope that that has been useful and informative, and I'm very happy to take any questions. I do wish to point out that I'm an occupational physician, so I have no expertise in surgery of the knee.
Yep. All right. Thank you, Dr. Dryson. Those were really interesting. Now we have head to the Q&A sections. Everyone, does anyone have any question for Dr. Dryson? If you do, please unmute yourself to ask. Anyone? All right. So actually, I have a question from one of my colleagues who was unable to attend today for Dr. Dryson. The question is there a difference in recovery expectations for workers with physically demanding jobs compared to those with sedentary roles?
Oh, that's true. We're talking here specifically about meniscal tears. So the meniscus does need to be under some form of strain in the job before we would accept that it's a work-related condition. So clearly a sedentary job done seated puts no strain on the meniscus at all. So any meniscal tear in an office worker, for example, must be by its definition a degenerative tear related to the aging process and not due to the job.
Yeah. All right. I'll note that down for it. All right. Thank you for that, Dr. Dryson. I think we need to wrap it up here. No questions from. All right. Thank you for sharing your appetite with us today. Thank you to everyone who attended today. Have a great rest of the day, and we're looking forward to seeing you at the next seminars. All right.
Thank you
Thank
very
you,
much.
everyone. Thank you, Doctor.